Well, this is going to be difficult. I apologize. This just came on this morning, so I couldn't even call somebody else up and say, could you go do this? If you'll bear with me, I'll try to be more concise than usual and try to get the main points across because I'm very pleased to be here and be able to speak about this. So my role is to speak about the list making, the idea of making lists as a way of understanding what works. And it does differ from the meta-analysis or a collective review, systematic review approach in two key ways to help understand the difference. It's complementary, certainly, and there are ways we hope that at some point they'll come together. But it differs in two key ways. One is the extent to which one wants to be trying to look for large categories so you have enough studies to do the evaluation versus you want to identify programs that can be used as is. The second is the extent to which the idea of methodology, quality methodology becomes a entrance ticket rather than something that you take into account and put into an account analysis. And so those differences lead to somewhat different outcomes of what you produce. Essentially, do you produce programs or do you produce practices and approaches? And this is the program approach. So just to start with, the first is to kind of step back a little, and I'm going to try to skip some of this because Daniel covered some of it, and I think Mark covered a good chunk of it too, and so it won't get. But one could say, when you want to say what works and what are we trying to find out here, you can look for lots of different kinds of evidence, and it depends on what you really want to use it for. And we don't talk about that much. We produce evidence, these single programs, and then we say, okay, it works, you should use it, and then oh yeah, there's something about implementation, there's some other pieces and so on. But you can go everywhere from you're really trying to test a theory, which is kind of what Mark's last slide was, to you're trying to decide which programs you should offer to fund, which ones you should implement, to what are the benchmarks you want to have for it's making a difference, how do you really know if something matters, small effects versus big effects, that kind of question. How applicable and useful is it for this population? Does it really work here? So we talked about the Baltimore-Chicago adaptation. How readily can it be implemented? Some programs have nice effects and everything, but they seem very difficult to implement. Some are very easy to implement that seem to have very little effects. And how important is fidelity? How much does a program have to be done as designed versus can be done with less money, less capability, and without as much direct influence of the developers? So does it work? Is it effective? That's what everybody wants to know. Anthony's legislator that calls up and says, I need to know by 5 o'clock what works. It implies a set standard for judging the quality and generalizability of the evidence. So in other words, it implies that we know what we mean by this works, that doesn't, and we know who we're talking about when we say that works, and that's generally not the case. Although I'm going to argue that blueprints is an example, at least in terms of standardization of the evidence, of the criteria for being included, has really focused on that, and that's a strength of it that we would like to see given more attention in other efforts, similar efforts. There are multiple strategies for estimating effectiveness. You've heard one that Mark talked about. We're talking about one. There's other ones that are used on other lists where they sort of give people a sense of how good the evaluation quality is and then how big the effects are, and leave it to other people to make that judgment. There are lots of other kinds of views too. But the point is there's limited consensus about what is the standards for identifying a program as evidence-based. That's forgetting about evidence-based programs versus practices and ideas that are being floated around like the practice-based evidence and things like that. People are floating out there as though these are identifiable, quantifiable, and useful for directing us. The idea that Blueprints is based on is let's try and use this kind of scientific standards that is used elsewhere in science to say you have a valid, reliable study and we can believe the results. And then the second part of that, replication is critical. And so we can replicate this, we can start to believe it. Otherwise, it's so unreliable, we want to be very careful not to use it. That's an important quality that we're talking about here. It's different than the idea that, well, we can't get good evidence because it's so hard to do, so let's use what we got. It's saying let's get let's make it clear we got to get the evidence that we can rely on, because relying on bad evidence, as we just talked about with this study of concealed weapons, can wreak havoc. So it may be better to spend time and effort on making sure we do better studies, is what I'm trying to say. So there are many ways to go about doing this. I'm going to skip most of this. These come from, you make interpretations of correlational studies to their systematic reviews that are done carefully. People look at trends and records. We've been talking about that this morning. And you get down to sort of two that really do seem to have the scientific capability to help us. One of those is conducting randomized trials, and the second is this systematic review of multiple tests of high quality. If you're going to develop a program, if you're going to go out there and see, does this work, it's a very difficult thing to do. I just spent 3 days in San Diego where they're developing a new health education program, and I kept saying, well, what is it? And they said, we think this is great. I said, what's this? And we just say, what is this thing, and get hold of it so that you could really test what it is that's working, because these, as Daniel so nicely indicated, these things get implemented in real world, and there's lots of other things going on. It's very hard to get hold of. And so you have to but you kind of have to put it in that box to really get a feel for it. So you really need what we call a theory, which is really an understanding of how does this thing work? Why does it make sense to do this? And then you need something about, is there some good reason to believe this might make a difference? Is there empirical evidence? And you also have to be focusing on things that can be changed. A lot of times policies are focused on things that are unlikely to be changed by the efforts. Whether that's starting something like ceasefire, but not funding it enough to really be implemented, or we're going to eradicate poverty and then we won't have crime anymore. And with the idea that we're going to somehow do that with very little money or something and very little effort. You have to have an outcome that is meaningful and behavior. In other words, it has to be something that matters. It can't be just interesting attitudes, or we want to have something that really, if it changed that, we really would care. And we need to think about who the appropriate population is. We need to have a certainty of effects due to the test. We need to be able to do that. That's, again, one of the wonderful things about randomized controlled trials. Why people who champion them so much is because it allows a simplicity of understanding that's very difficult to get otherwise. They give us a confidence that we can't get from almost any other method. And they, in that sense, I think they wind up being more efficient and perhaps more cost-effective studies than many other correlational and quasi-experimental studies. Also, the study has to be completed adequately to believe it was actually done. There's a lot of fall-off between what's designed in the office and what gets done out on the ground and what's there after it's been implemented to see whether or not it does work. And so all of those things become things that make it very different threats to being able to determine, does this thing really work? Is it something that we really can know what it tells us? And also, we should hope that it lasts beyond the immediate, that it's not just something that our immediate attention to that is making the difference, and as soon as we leave, it'll stop. So I'm going to skip most of this slide. These are technical reasons why you might have randomized trial, or you might have a very good quasi-experimental, but you still don't get scientific data that really can be relied on and should be relied on. It's why there's such a concern about how come you'll require randomized trials in blueprints, and why do you require those in some of the other registries? It's because it's so hard to do. And also, or some people will talk to me when they get me in a corner, why are you guys so picky? And we try to explain why we're being picky. Because these things all matter in the extent to which we can believe those numbers. And as, again, we saw with this concealed weapon thing, numbers get very real, get very relied upon, and it's up to us to make sure that what's being presented out there is something that you really want to rely on. That's the basic idea. So the critical issue is, can you reject plausible other explanations for what you think is a difference? Your program made a big effect. You want to go out and get the whole world to do it. Is there a reliable, is that reliable? Is there a good belief that that's pretty true? That's not there's not something else going on, and you're either kidding yourself or kidding others. So that's the blueprint strategy. To go about and proactively, systematically research and review individual programs that have been out there and been evaluated, and to identify prevention and treatment programs that meet a high standard. And I put high in quotes because this isn't a high standard. It's actually a good standard for research and evaluation. It's a high standard because it's relatively rare to do, it's difficult to do, and it's quote unquote expensive. It's only expensive because we're used to living on pennies. It's not really expensive in terms of the amount of money it would take to do some of these larger trials. It just seems like it because for some reason there's a belief that spending a decent amount of money in this area is a luxury. So Blueprint started out focusing on violence and drug abuse and delinquency. We've now expanded to start to focus on mental health, educational achievement, and physical health, and to apply the same standards in those areas, particularly working with the Annie Casey Foundation. So we have a staff whose job it is to systematically search for and identify studies, so we don't wait for people to submit to us, and we don't wait. We have people literally go through the literature on a monthly basis, looking for what's been published or not published, but is available that might be relevant and might be potentially have the qualities we need to be considered to be able to tell us whether or not that program does work. Once the staff goes through, if they meet what look like the basic criteria for potentially being a good study, and therefore we can know what the effects are, the program then is brought to the board, and one of the board members, and sometimes two, will systematically review all the material available on that. Sometimes we'll solicit material from developers to see if we can get as full information as we can, because many times in articles, not all the information we need is there, and we don't want to have people penalized for that. And then when we look through, and I'll go through in a minute what the criteria are, if studies seem to have validity and the programs they're studying seem to have positive effects, then they're certified as either a promising or a model program, depending on the replication and the sustainability of the effects. They can be at two different levels. And I'll go through that in a minute. And our point is that we see models as what should be relied on for dissemination. And there aren't a lot of those. And that's a criticism we hear and we share. We wish there were more. On the other hand, we're not therefore going along with the idea that we should do lots of other things and not worry about the criteria. We're not sure that if you have a flashlight that only allows you to go down 12 paths, that you should just start walking around in the dark and figure that that's a good way to do things. We think you should try to, for now, follow those 12, 13 paths. Here's the, excuse me, the fact sheet that gets developed for blueprints. People often wonder how is this done, and Mark was talking about transparency and consistency, and that's one of our hallmarks and one of the things that we see as critical for development of lists, whether it is about practices or about programs, is that there's a consistent way in which things are evaluated, an objective way and a verifiable way, and that information is available to the people charged with reviewing, so it can be done systematically. So we look at what are the outcomes, what are the risk and protective factors that are targeted, what are the target populations of interest, so we can know if we find something is a model or a promising program for whom, what are the effects, what are the effect size, and what area in terms of influences on the child or the family or the population is the focus. We also want to understand what's the model, the theory of how this should work, what are the program costs, what are the benefit costs, how is it, what's the funding that's required to get it going and to sustain it, and what kinds of program materials and references are available. So all that is available for each of the programs that have been reviewed in our model or promising program, and I believe are also available for the programs in which that was not the case. I'm not 100% sure about that part. But all this information is available on the website for each of the programs. So one could go in fact, one can go in now and say, here's the kind of area I want to work in, here's the outcome I'm interested in, and it'll list a set of programs that would meet those criteria from the promising and model programs. The difference between a promising and a model program is, as I said, replicability and sustainability. So a model program has one high-quality randomized controlled trial or two high-quality quasi-experimental studies that we can can have confidence there isn't bias that's substantially affecting the results, that there's significant positive effects, p less than 0.05 essentially is what we're talking about here, and there's no health compromising effects of that intervention. And those effects can be immediate, meaning they're right at the end of the intervention. Because we're interested in prevention in particular when we started this, but also because we believe even with treatment, the goal, and even education, the goal is lasting effects. We're looking for sustained effects. And so to be a model program, there has to be at least one replication, one of which is an RCT. So it has to be at least one randomized trial, and the second one can be a high-quality quasi-experimental design, both with significant positive effects and no health compromising effects, and at least one of those showing sustainability 12 months beyond the completion of the program. So it has to last for at least a year. Now, I'm going to talk about where we're going to go and where we'd like to go and where we think things should go in trying to deal with the complementarity, but also some reconciliation of the meta-analytic and the list approach, because clearly the answer is that these both have great value. And so ideally, we would be able to do meta-analysis of multiple RCTs of a given program. That's very, very difficult to do. Replication is not a very well-funded area of study. It's hard to get a grant to do that. It's not very exciting for your career to be the person who replicated somebody else's work, as well as you have to do a fair number of these before one has the kind of numbers that meta-analysis really can give you a reliable indicator that another study won't change things a lot, just like in other types of sampling. So there's an issue of getting enough studies to do that, and to be able to say, does this program really work, as opposed to, as Mark said, somebody worked really hard and managed to get themselves an unrepresentative effect, but it looks like it's positive. Or because they didn't have the resources, they got no effect, and representative effect would be significant. But in practice, it's really a review of each study to see if that study has an effect. And we've had long and extensive discussions among ourselves and with other people and experts about the problems of that and the benefits of that, but have taken a position at this point. The idea is to promulgate, if we can, a reliable list of programs that people could use, and that the idea of two studies that independently have been done and have reached a level of significance that's been a standard in the science, we decide that's pretty good, and it stands up against other criteria. And here's an example, which there's not for now, but at another time there could be an interesting discussion about this back and forth between meta-analysis and the list kind of thing, where we've had two programs that were subjected to, that are on blueprints models that were subjected to meta-analyses, and there were significant issues, whether those issues mean that the programs really don't work or they do work would be something that I won't take a position on right now. But the point being that it really needs to be thoughtful about how we move from replication as two studies independent versus we're going to look at general overall effects of whatever's available on a given approach. These are a list of the evolving kinds of considerations that Blueprints is going through as we try to continue to move forward, and as the science evolves and as wonderful and important contributions and advances come in methodology and the number of types of interventions that are out there. Probably two that are most critical are the issues of how do you get adequate power and adequate number of examples of studies that are group randomized trials. That is, they're focused on settings or populations or people under certain conditions rather than the people being directly affected, because they are more complex to implement. They challenge the typical kinds of funding levels and funding formulas and priorities that we have in research. So we don't want to be underestimating the value of these approaches because of those limitations. So we've been working on the idea of maybe somewhat different criteria for those than we've been looking at, which the studies that are done typically focus on individuals as the outcomes. Trying to see whether or not things like regression discontinuity and other quote-unquote non-experimental methods of trying to find causality are alternatives that might be useful and could help with this kind of difference is another question of great importance that we continue to try and be educated about and think about. And the last thing I'll talk about in terms of things we're trying to move forward to is the idea of bringing in effect sizes and cost-benefit ratios as part of evaluating studies. So in other words, trying to bring that information forward, and where should that be? So the question of you have an effect of p less than 0.05, the effect size is relatively small, but the cost-benefit ratio is pretty good because it affects lots of people. What do you do with that study? Or you could think of other examples there that challenge any one of those single criteria. Del Elliott, who chairs this and has been the leader on this, has been working over the years with federal groups working on standards to try and create consistency across the lists for the standards. My own little bit of our argument has been that that's one of the major reasons we get held back in the use of these lists and the qualities lists is that we have different standards for what are very similar looking lists. And if I had time today, I could give you an example in Virginia of trying to use lists and having people really not able to understand why they're different. And if it's on a federal list, doesn't that mean it works? Would be the quote that succinctly explains the problem. So the idea of trying to come up with consistent criteria, and these are the criteria that came out of a federal working group about, I think it was about 9 years ago, 10 years ago now. I think some of the people here were involved in this, of trying to come up with these criteria. They look like blueprints criteria, only with a somewhat different, which is the idea of the independence of replication. So one of the ideas is that you have to have a replication that's done by somebody else. And that led to really a 4-level kind of idea of evaluation for all programs. So every program would be, 5, sorry. Nope, there's 6. Sorry, I keep forgetting. But 4, and one, the harmful part is important because the idea is to require the same standards for saying something's harmful as you do for saying it's effective. No, okay, sorry. So defining evidence base. The argument here is to define evidence base as something that meets those criteria because evidence base has now come to have its own value. And one has heard, particularly in the last couple weeks, a month, a lot about evidence for this, evidence for that. And so the idea that what is evidence starts to get very important in a way that isn't just a technical interest of a few of us. It's really about how do we know what we're talking about when we're talking about evidence-based, so we have a shared understanding, but also what is it that we're offering people. So when people are trying to make use of the kinds of things that Mark was talking about, we're giving them reliable information that we all would recognize as. These are the ideal characteristics of an evidence-based program. As you can see, it does all things for all people, particularly all evaluators, and that's what we're aiming for. We're probably a couple generations from that. Thank you. These are the web pages for our center and for the Center for the Study of Prevention of Violence, University of Colorado, and that's where all the blueprints information is listed. Thank you.